Welcome all to the today's presentation. Today we will be discussing guideline from fertility module. It is a fertility problems assessment and treatment NICE guideline published in February 2013. We begin with our code Master MRCOG with concept oriented clarity. This guideline is going to be very important from part 2 MRCOG. You will have at least 2 SBA and 2 or 3 EMQs also from this particular topic. So please listen to each and every slide very carefully. So when we are having consultation with infertility couple, what should be our advice to this particular couple? The guideline says if the couple is trying for natural conception, in that particular case, we need to discuss about the chance of conception. Okay. So what we need to tell, more than 80% of couples will conceive within 1 year if the age of the woman is less than 40 years, they are not using any contraception, and there is a regular sexual intercourse. So if this criteria, that the young reproductive age group where the woman's age is less than 40, not using on any contraception, and they are having regular sexual intercourse, the chance of conception is more than 80% will conceive within 1 year. Okay, this is important from SBA point of view. Okay, and those who do not conceive at the end of 1 year, another 50% of those who will not conceive will conceive in the second year. Okay, so the cumulative pregnancy rate at the end of 2 years becomes more than 90%. Okay, so this figure is going to be very important. At the end of 1 year, more than 80% will conceive. At the end of 2 years, more than 90% will conceive. Please read the question carefully, what they are asking. Okay, they may ask you how many couple, those who have not conceived in the first year will conceive. There is a 50% chance among the couples who have not conceived. Okay, so 20% have not conceived, among this 50% will conceive, so overall it becomes 90%. This is important from SBA point of view. 1 year 80%, 2 year 90%. Okay, now if the couple is on IUI protocol, there are very specific indications for IUI, so that also we will see in the subsequent slides. Okay, if the couple is on IUI protocol, in that particular case, how many will conceive in the first 6 cycles? More than 50% will conceive in the first 6 cycles, provided the woman's age is less than 40 years. Okay, now if additional 50% will conceive in next 6 cycles. Okay, so the cumulative pregnancy rate at the end of 12 cycles will be more than 75%. Okay, so if whether they are trying naturally or whether they are for IUI protocol, for natural conception, more than 80% at the end of 1 year, 90% at the end of 2 years. For IUI 6 cycles, it is more than 50%, and additional 50%, that means total 75% at the end of 12 cycles. Okay, so these are the rates which you should remember from SBA point of view. Now, what about the semen preparation? Okay, uh, if is there any difference with respect to fresh sperm and the frozen sample? Okay, fresh sample or the fresh sperms are always better than the frozen thawed sperms. Okay, there is a higher conception rate. Okay, so whether the conception rate differs with respect to the type of specimen, so fresh sperm are better than the frozen thawed sperm. Then with respect to the type of insemination, whether it is IUI or intracervical, it is IUI which is always preferred over the intracervical. Even with frozen thawed sperms, you prefer IUI. Okay, so for exams, you remember IUI is preferred over the intracervical insemination. Is there an effect of the age? So female fertility declines with the age, while male fertility also decline, but to a lesser extent. Okay, frequency and timing of intercourse or insemination. Sexual intercourse, there should be vaginal intercourse every 2 to 3 days. That will optimize the conception. It also avoids need for ovulation prediction kits in routine practice. Okay, and artificial insemination, IUI should be timed around the time of ovulation. Okay, now regarding advice regarding the alcohol. Okay, for male and female. So what is the advice? Recommended intake when trying to conceive, women should have less than 1 to 2 units once or twice weekly and avoid intoxication. Okay, and for men, the Department of Health has given the limits that it should be less than 3 to 4 units per day. What is the effect on fertility in females? there is a excess intake will reduce the fertility, while in men, moderate intake is unlikely to affect the fertility. Effect of excessive alcohol, there is an increased risk to the developing fetus, while in male, it is detrimental to the semen quality. The key advice is advise minimal intake for females and advise moderation for the males. Okay. Now coming to the smoking and fertility. What is the effect of active smoking? Active smoking reduces the fertility in women, while passive smoking is likely to reduce the chance of conception in females. There is an impact on fertility, which is a clear negative impact on the fertility, and clinical advice for females will be offer smoking cessation referral. Okay, so any couple, or if you are having in part 3 station on subfertility where the lady is smoking, you have to offer the smoking cessation referral. Then for men, smoking is associated with the reduced semen quality. Overall impact is uncertain, and stopping smoking will improve the general health. Is there any effect on caffeinated beverages? There is no consistent evidence which is linking with tea, coffee, cola with the fertility problems. Now coming to the weight or the obesity in men and women. If the lady's BMI is more than 30, the time to the conception is longer. Okay, and if the woman is unovulatory, in that particular case, weight loss will improve the chances of conception. The best strategy is a group program, including the diet and exercise. For men, if it is a BMI more than or equal to 30, it is associated with the reduced fertility and poor semen parameters. Okay, so if you are given a scenario, please look at the BMI, and if they are asking about the initial treatment, it will be weight loss. Okay, so or the diet plus exercise. So look at the BMI and what they have asked, whether it is a non-pharmacological or the initial treatment. If they have asked, if it is a medical treatment, then it will be different. Or if this particular stage has already been implemented, that is the lifestyle modification has already been done, then you go for medical line of treatment. Okay, so exam related important points are: every 2 to 3 days intercourse is optimal. IUI is better than intracervical insemination, and always address the modifiable factors like smoking, alcohol, obesity, etc. And avoid unnecessary interventions early. Okay. Then folic acid supplementation. What is the recommendation? All women intending the pregnancy should take folic acid 0.4 milligram or 400 microgram daily. Okay, they should start before conception and they will continue till 12 weeks of gestation. Now, there are certain high risk women who should take 5 milligram per day folic acid. Now, which are those? The previous infant with neural tube defect, on anti-epileptic drugs, and diabetes mellitus. Okay, so if you are asked about the folic acid dose, please remember in which category. Whether she is in a low risk category, then it is 400 microgram. If she is a high risk woman with these factors like a previous infant with neural tube defect or anti-epileptic drugs or diabetes, she will require 5 milligrams per day. Okay. Now, what is the definition for infertility? It is a failure to conceive after a defined period, after which formal investigation and possible treatment is indicated. And when we are assessing a couple, we should always ask for lifestyle history, sexual history, and both partners should be evaluated. Okay. Now, when to investigate? Now, if it is they are on a regular, or they are trying naturally on regular unprotected intercourse, the waiting period is 1 year. Okay, so the timeline for the investigation is 1 year if uh, they are in a reproductive age group and trying naturally. Okay, if the couple is on IUI protocol, then this after 6 cycles of IUI, we have to investigate. If the age of the lady is more than 30 or equal to 36 years, early referral is indicated. If the cause is known or there are risk factors like maybe PID, endometriosis, etc., if they are known, in that particular case also early referral is indicated. Gonadotoxic treatment, if it is getting planned, say for example cancer chemotherapy or something like that, she also requires immediate referral. So the timeline also you should remember, and what kind of protocol or is there any associated factor is there, like PID, endometriosis, or any cancer treatment that we should take into account, and accordingly we need to investigate. Okay. Now coming to the investigations of fertility problem. the investigations of fertility problems. For male, it is always a semen analysis. But key rule is that do not screen for anti-sperm antibodies. Okay, so they may give in the scenario, sometimes following test are indicated. So it is just a routine semen analysis which is required. Routinely, anti-sperm antibodies are not indicated. If the semen test is abnormal, then you have to repeat the test. And when you will repeat the test, ideally the test is repeated after 3 months. Okay, but if your initial report shows azoospermia or severe oligozoospermia, then you will repeat it immediately. Again, here there is a SBA. They will give you the semen analysis report, and they will ask you the next step. And this is the first semen report. Okay, then look at the report. If there is a minor abnormality, maybe single parameter, there is a just deviation below the normal, in that particular case you will advise the repeat semen analysis after 3 months. But if it is a severe if there is azoospermia or severe oligozoospermia, then you will repeat it immediately. Okay, then postcoital test is not recommended. There is no predictive value of PCT or the postcoital test for pregnancy rate. Okay, now these are the parameters WHO 2010 criteria. These are the followed criteria for our exam. Volume should be more than or equal to 1.5 ml. pH should be more than 7.2. Sperm concentration more than or equal to 15 million per ml. Total sperm count 39 million per ejaculate. Motility at least 40% should be motile, and progressive motility should be 30 to more than 32 or equal to 32%. Validity should be more than or equal to 58%, and morphology should be or equal to more than 4%. Any of the parameter can be asked in SBA, or they can ask you the abnormal parameter. Okay, and they may give you combinations of these. Okay, and one of the value will be abnormal. So this particular values you should know very well. Okay, coming to the next, we have seen about the investigations for male partner. It is a semen analysis. Now coming to the female partner, it is the ovarian reserve testing. The first predictor for the ovarian reserve is a woman's age. Okay, that is the best initial predictor for both natural as well as IVF success. Okay, now coming to the predicting response to the gonadotropin. If the patient is for IVF, gonadotropins are most commonly used. Then what is the predicting, which are the factors which will predict the response to the gonadotropin? Okay, they are AFC, okay, that is antral follicular count, then AMH levels and FSH. Okay, so low response with the gonadotropin is seen if the AFC is less than or equal to 4, if the AMH value is less than or equal to 5.4, and FSH value of more than 8.9 international units per ml. So these patients are associated with low response, while high response to the gonadotropin is seen when the AFC is more than or equal more than 16, AMH is more than or equal to 25 picomoles per ml per liter, and FSH is less than 4 IU per liter. Okay, please remember these values, and units also you should remember. AMH is more than or equal to 25 picomoles per liter is associated with high response. Okay, FSH of less than 4 is associated with high response. Okay, now which parameters are not to be used for ovarian reserve testing? That is ovarian volume, ovarian blood flow, inhibin B, estradiol. Please do not select these options in your answer. Okay, now coming to the assessment of ovulation. Menstrual history is going to be very, very important. If the cycles are regularity, most likely she is ovulating. Okay, but what will be the test for ovulation? It is always a progesterone testing. Okay, and that should be the mid-luteal serum progesterone. And for a regular 28-day cycle, it is done on day 21. Again, here is a single best answer question which is very commonly asked. They will give you that her cycles are 28 days or 35 days, and they'll ask you when will you do the test for ovulation. If it is a 28-day cycle, then it should be done on 21 days. If the cycles are irregular, then you have to adjust the timing of the test. Say for example, if it is 35 days, okay, then you will do it on day 28, okay, because ovulation happens 14 days prior to the expected periods, okay. And so you will adjust the timing for the longer cycle and repeat weekly if the cycles are irregular. Then basal body temperature for ovulation assessment is not indicated. If her cycles are irregular, then we will also do FSH and LH. Okay, prolactin routinely is not measured. It is to be done if we are suspecting ovulatory disorder or galactorrhea or pituitary tumors. Thyroid function, routinely TFTs are not recommended unless the patient is symptomatic. Endometrial biopsy also not routinely indicated. Okay, for luteal phase defect, there is no evidence treatment improves the pregnancy rates in cases of this. Okay, by this endometrial biopsy. Okay. Now coming to the tubal and uterine assessment. So what we have seen up till now is the semen parameters we have seen for male factor. In female factor, we have seen the ovarian reserve. Now coming to the tubal and uterine assessment. So what does the guideline says? So for tubal assessment, which test we should do? Now, if the patient is low risk, that means she does not have any history of PID or ectopic or endometriosis. HSG is the test of choice. Okay, the test of choice will be hysterosalpingography if she does not have any factor, high risk factors such as PID, ectopic or endometriosis. If the expertise is available, then you go for HICOC. Okay, contrast hysterosalpingography. Okay, salpingosonography. Then if there are any comorbidities, then you go for laparoscopy plus dye test. Okay, so these are the tests which you need to select depending upon the scenario which is given to you. Hysteroscopy is not routinely indicated, and it is only when you suspect some pathology. In that particular case, you will offer her hysteroscopy. Okay, otherwise for tubal assessment, these are the tests: HSG, HICOC or laparoscopy plus dye test. Now if there are special situations like viral testing for various viral investigation infections such as HIV, hepatitis B and hepatitis C. If it is a positive, then you have to do the specialist management, and you have to do the counseling of the patient. Okay, viral transmission and fertility, then we have to discuss the various options for the management. Okay, it should be made jointly by the couple, the fertility specialist and the HIV specialist if it is a HIV positive couple. Okay, now this scenario can also be asked. Please concentrate here. There is a negligible risk of HIV transmission with unprotected intercourse if all conditions are met. Okay, here there is a discordant couple. That means the wife is negative and the husband is HIV positive, and if the husband satisfies the following criteria, in that particular case, unprotected sexual intercourse around the time of ovulation is the option for the conception. Okay, not the IUI. And not only that, they do not require any pre-exposure prophylaxis also. Okay, there is a negligible risk of HIV transmission with unprotected intercourse if all conditions are met, such as male partner is compliant with heart, that is highly effective ART, antiretroviral therapy, plasma viral load is less than 50 copies per ml for more than 6 months, there are no other active infections, and intercourse is restricted to the ovulation period. So only periovulatory intercourse is there, then there is a low risk of transmission. Okay, when all above criteria are met, sperm washing does not further reduce the transmission risk, and if it is done, may reduce the chances of pregnancy. Okay, so negligible risk of transmission if all these criteria are met. So when such a scenario is given to you, please look into it whether these criteria are satisfied or not. In that case, what you will select: unprotected intercourse around the time of ovulation and no pre exposure prophylaxis. Okay, so in which cases the sperm washing is to be offered? When these criteria are not met. That means male partner is not compliant with the heart, viral load is more than or equal to 50 copies per ml, sperm washing reduces but does not eliminate the HIV transmission. That needs to be counseled. But by any chance, even if all the criteria are met, but the couple doesn't want to take a minor chance also, risk also, in that particular case, you will still offer them the sperm washing, but you will counsel them. If criteria are met, but the couple still feels that is unacceptable, sperm washing may be considered after specialist discussion. Okay, but we need to tell sperm washing reduces but does not eliminate the HIV transmission risk. Okay, there is insufficient evidence to recommend pre-exposure prophylaxis for HIV negative women when all low-risk criteria are fulfilled. This also we have seen. Okay. Now, if it is a hepatitis B positive, then what we will do? Offer vaccination before fertility treatment. Okay. Uh, if the partner is hepatitis B positive, other is negative, what you will do? You will offer the vaccination before fertility treatment. Now, if it is a rubella, now we will do the rubella testing for this lady. If she is not immune, we can vaccinate and avoid pregnancy for 1 month. Again, this is one of the SBA. If the lady has recently taken rubella vaccine, then the pregnancy is to be avoided for 1 month. Then cervical screening, always ask about the last smear, screen as per the national program, and avoid delaying the fertility treatment. Coming to the chlamydia testing, screen before the uterine instrumentation. If we are doing any instrumentation, check whether the chlamydia test has been done or not. If it is a positive, we need to treat the woman and partner and perform the contact tracing. Okay, if the chlamydia test is positive, we will treat the woman and then only we will perform the test. If she is not screened, then we will give the prophylactic antibiotics. Okay. So what are the important points from examination? Referral trigger or the timeline for the referral is 1 year with natural conception, 6 cycles after IUI, and after 36 years, then as early as possible. Okay, age is one of the better criteria for ovarian reserve prediction. HHG is the first test for or preferred test for tubal patency if there are no associated comorbidities. Then routine prolactin, thyroid function test, endometrial biopsy is not indicated. HIV, if it is well controlled and all the criteria are satisfied, natural conception is acceptable. Okay. Then coming to the male factor infertility, medical management. Okay. Suppose there is a hypogonadotropic hypogonadism. The treatment of choice is a gonadotropin. It is effective. Okay. Now, if there are idiopathic semen abnormalities, then what is not to be done? Then do not offer anti-estrogens, gonadotropins, androgens, bromocriptine, kinase enhancing drugs. These are not to be offered. Okay. If it is a hypogonadotropic hypogonadism, gonadotropins you will give. Okay. Again, sometimes they can ask you about anti-sperm antibodies, and most of the time the candidate selects the steroids as a treatment of choice. Anti-sperm antibodies, again, there is no role of the steroids. Okay, significance of the anti-sperm antibodies unclear, and systemic steroids are not proven, so please do not select the systemic steroids. Okay, leukocytes in the skin. So read the scenario very carefully and look at the other parameters, and as per the other parameters, whatever is the best option for that couple, you go ahead with that parameter. Okay, with that option. Then there are leukocytes in the semen. Again, antibiotics are not indicated unless the infection is identified. Okay, so only on the presence of leukocyte, do not offer the antibiotics. So read the semen analysis report very carefully and then select the appropriate option. Okay. Now coming to the surgical management for the male infertility. If it is obstructive azoospermia, now if it is obstructive azoospermia, in that particular case, surgical correction of the epididymal blockage that can be offered. Okay. If it is a varicocele, again, sometimes the question has been asked on the varicocele, surgery is not recommended. There is no pregnancy benefit by surgical treatment of varicocele. For ejaculative failure, treatment may restore fertility without ART. The evidence is limited and you have to individualize the management. Coming to the ovulation disorders, that is the female partner. Now, we know well that the WHO classifies the ovulation disorders into three groups: group 1, 2, and 3. Group 1 is hypothalamo-pituitary failure. Group 2 is hypothalamo-pituitary dysfunction, in which the most common condition is a polycystic ovarian disease or polycystic ovarian syndrome. And group 3 is a ovarian failure. Okay. Now, WHO group 1, that is hypogonadotropic hypogonadism. Now, in this particular case, most of the time there will be a patient will be thin. There will be either anorexia or excessive exercise history. In that particular, you have to give the lifestyle advice, ask the patient to increase the weight or optimize her BMI. So if the BMI is less than 90, she should increase the weight. If she is having excessive exercise, then it needs to be moderated. Okay. Then ovulation induction, the treatment of choice will be pulsatile GnRH or gonadotropins with LH activity. Okay. So you have the treatment of choice as a pulsatile GnRH or gonadotropins with LH activity. While the same treatment is not preferred here in WHO uh, 2 category. Okay. Now coming to the WHO category 2, the first line management here will be here in this category we have polycystic ovarian syndrome. So management option will depend upon the BMI, response to the treatment, side effects, monitoring needs, and the patient's preference. So if the BMI is more than 30, we will advise first the losing the weight. Again, this is the SBA or EMQ have been asked in the past on this. They'll give you the BMI more than 30, that is 30, 32. They'll ask you the initial management. It will be the weight loss. Okay. So weight loss alone will restore the ovulation, improves response to the ovulation induction, and improve the pregnancy outcome. So the first option in this particular scenario will be the weight loss. Okay. Now first line ovulation induction options. Now for ovulation induction, we have clomiphene citrate, metformin, and combination, that is clomiphene citrate plus metformin. Clomiphene citrate is the first line ovulation induction. Metformin is useful especially if she is overweight, PCOS. Okay, in those patients metformin can be started, and combination, that is clomiphene plus metformin, it can be used as a first line agent also. Okay, sometimes they can ask you about the clomiphene resistant. This is also a scenario which has been asked. Okay, now what are the safety rules for clomiphene citrate? Ultrasound monitoring at least in the first cycle should be done. It reduces the multiple pregnancy risk. Okay, then maximum duration should be around 6 months and do not continue beyond 6 months. Metformin, we have to counsel about the side effects, that is the nausea, vomiting, and GI disturbances. Now here also they can ask you the scenario about clomiphene resistant WHO group 2 disorders. Okay, what is the second line treatment? The first line we have seen, if born BMI more than 30, weight loss, and the medical management. Medical management, we have clomiphene citrate, metformin, and metformin plus clomiphene citrate. So these were the three options. Now second line. In second line, we have laparoscopic ovarian relief, clomiphene plus metformin, and gonadotropins. Okay. Now which option? Again, that will depend upon the scenario which is given to you. Okay. Now, if they have used only clomiphene, in that particular case, you can add the metformin. Okay, you can use clomiphene plus metformin if it is not already used. Okay, then laparoscopic ovarian drilling (LOD). Okay, if the patient is thin and if the LH levels are very high in that particular case, you can use the laparoscopic ovarian drilling. And gonadotropins are effective, but it needs the strict monitoring. Okay, so in the second line, you have these three options, but appropriate option for that scenario, you will select depending upon the information which is given to you. Okay, now what is not recommended? GnRH agonist with gonadotropins. There is no pregnancy benefit. Adjuvant growth hormone and pulsatile GnRH. Okay, so pulsatile GnRH is not indicated in group 2, while in group 1 we have mentioned that pulsatile GnRH or gonadotropin with LH activity is the treatment of choice for group 1, but for group 2, pulsatile GnRH, there is no effect. Effectiveness is uncertain. Okay. Now coming to the hyperprolactinemic amenorrhea. Okay, in these particular patients, so what we will do, we will offer dopamine agonists like bromocriptine, and prescribing should consider safety in pregnancy and the cost. Monitoring during the gonadotropin therapy. Before starting, we will counsel the patient regarding multiple pregnancy risks, ovarian hyperstimulation syndrome. Okay, during the treatment, mandatory ovarian ultrasound monitoring to assess the follicular size and follicular number, it is must. Okay, so from exam point of view, remember BMI if given more than 30 or equal to 30, weight loss is the first, that itself may restore the ovulation. Second, clomiphene USG follicular monitoring at least in the first cycle. Maximum you will give 6 cycles. Clomiphene resistant, then you have various options. Clomiphene plus metformin. If this metformin is not already tried, then laparoscopic ovarian drilling, you have option. And second is a gonadotropins, that is GnRH agonist or GnRH agonist or growth hormone. They are not recommended. Okay, so you have LOD and gonadotropins. Okay, in gonadotropins, mandatory counsel regarding the multiple pregnancy and OHS and ultrasound monitoring. So for exam, if the question says clomiphene resistance PCOS, then always look for add metformin or LOD or gonadotropins. Okay, so you will select one of these options. Now coming to tubal and uterine surgery. If it is a mild tubal disease, then tubal surgery may be beneficial. Okay. If there is a proximal tubal block, in that particular case, tubal cannulation or selective salpingography. Then if it is a hydrosalpinx, then you will perform salpectomy before IVF. Okay, that increases the live birth rate. Okay, so this tubal surgery is indicated only for mild tubal disease. For proximal tubal block, you have tubal cannulation and selective salpingography. Hydrosalpinx, you will go for salpingectomy before IVF. Uterine surgery, such as intrauterine adhesions, and there is amenorrhea, then you will do the hysteroscopic adhesiolysis. And for endometriosis, we will treat as per the NICE guideline and the USHTI guideline. Okay. So that finishes the investigations and treatment. Thank you.